So hi everyone, my name's Rachel Moses and I'm a consultant respiratory physiotherapist working in the northwest of England in the United Kingdom. And I'm doing this podcast today on behalf of Physiopedia as part of their COVID-19 educational package, as I've been part of a collaborative that have just produced some recommendation guidelines in the physiotherapy management for COVID-19 patients in the acute hospital setting. And I do have to start by saying this was a brilliant initiative set up by our Australian colleagues, in particular Dr. Peter Thomas, who's a consultant physiotherapist based in Brisbane, Australia. So he really did lead the development of this and was absolutely fundamental. And I'm joined by one of my co-collaborators, Bernie. So hi Bernie, do you want to tell us a little bit about yourself?
Hi Rachel, sure. So thanks for inviting me to have a chat today. So I am an associate professor in physiotherapy in Canberra, Australia, and I'm also a visiting academic physiotherapist at Canberra Hospital, and I'm an ICU physio by background. I've been working in ICU for 20 years, and it's been absolutely fabulous to be part of this process where we are sharing our ideas with the world.
Fabulous. So many people probably know Bernie and know she's got quite a diverse clinical and academic history, and I think that's what's really important about this guideline. Actually, it started off as quite a small team, didn't it, Bernie? And then it kind of evolved, and I remember getting an email from George saying, "Oh, you're banging out some guidelines there in the UK. Do you want to come and join this team?" And then Rick was involved, and we had Michelle from Canada. So I think that's absolute kudos to the team, because they're seeing an opportunity to actually develop and actually, invite people in to the conversation and produce these guidelines that were originally meant for a specific population of physios, but actually become international guidelines, which is brilliant.
Mm.
So do you want to start off a little bit about where it even started? So I've mentioned Peter had the idea,
Yeah.
like what
I can actually even go a step further back from that. So Ayanthi Bowden is a physio in Australia that some would be familiar with. She's led some amazing studies about physiotherapy prior to abdominal surgery. And I got an email from her, it was like only a week ago, that's the crazy thing, saying, hey, do you want to be, we're trying to put together some guidelines. Would you like to be part of this group that we're trying to write some documents so that all the physio managers around the world need some information about what they need for staffing, how they're going to cope with this crisis, and do you want to be part of that? And could you link us in with Rick Gosling? And of course, I had the extraordinary fortune to spend more than a week with Rick Gosling last year when I came and did my sabbatical over in Europe. And so it was fabulous to be able to connect with Rick and say, hey, Rick, we're trying to pull together this guideline. Here's an introduction to Ayanthi. Could you be part of this group? And it sort of, honestly, within 24 hours, it sort of snowballed, pulling people together to come up with these guidelines, because it was very clear very early on that there was this absolute desperation in Australia from physiotherapy teams and ICUs around our country going, we don't really know what the game plan is here. We're a bit stuck. Mm-hmm. And we know that we've got some physios out there with some expertise, but we're not really sure what the right thing to do is. And so rather than each individual little jurisdiction trying to put together their own sort of document of dot points, this group sort of came together, and Peter Thomas, who's an extraordinary physio to be part of this group, he said, hey, guess what? I've already started something. And he shared this document that he had put the bones together of, which was quite largely informed by the ANZIC, so Australian New Zealand Intensive Care Society guideline that was already published. And he said, hey, if we can align our recommendations with the ANZIC's guidelines and kind of hinge from that, then I think that we're going to get some traction with our recommendations, and that they could actually be implemented. And of course, it was a no-brainer that this was something that was relevant not just to Australia and New Zealand, but of course around the world. And so the opportunity to include yourself, Rachel, as well as Michelle Coe and Alice and Rick, it was just a fabulous meeting of expertise so that we could pull together everything that we knew. Obviously, we've all got our little niches of expertise and special areas, but if we could bring that all together to inform this one document, then we hoped that this would come up with something that would be absolutely practical and meaningful and give physio managers and frontline clinicians a roadmap, if you like. And I think that's the point that we got to. I don't know if that's how you're feeling about it, but that's kind of
definitely. I mean, I think it first started off as something really big, and then there became a clinical need because things started to escalate. So in each of the countries, we were seeing changes in presentation of these patients and numbers, and it was that slow drip effect at the start of the curve. So then when Peter sent the original table round with what he'd done, as you said, it was like, this is exactly what we need right now, and we need to put the meat on the bones. And I think with regards to the work you all done together, you all had a vision of what the clinicians needed. And I think that's why it was such a strong group, because you had that academic insight to know where we can pull evidence from that just doesn't exist right now, and then make it into as evidence-based recommendations as that you could, because you drew on other evidence from that coexisted. So that kind of brings us on to the approach, like the methodology. So we started off with a table with something that we knew we wanted questions answered. So how did it develop from there?
Yeah, so I guess the decision of the group was really that we wanted some sort of consensus document. So because we didn't have randomized control trials in COVID-19 patients, we didn't have that data. We needed to each sort of separately consider what is the data that's out there, what do we know, what can we reasonably extrapolate from the studies that are perhaps in different populations, and then how do we use that to inform this guideline. And so in this table there was a number of statements about what was a reasonable or not reasonable thing to do based on the limited evidence that we have. And then each member of the group was asked to vote on whether they would agree or disagree with that statement. And before launching this process, it was determined that we needed at least 70% consensus for a statement to be considered agreed with. So once we'd sort of nutted out what those statements are, largely informed by Peter Thomas, then each individual member of the group took that table away and spent, I did quite a few hours thinking through the evidence, looking things up, going and refreshing our minds about what is the evidence, is that strong enough, is it level B evidence, for example, and then coming back to those statements and saying yes or no, or no, because I think of this particular thing as an issue, or yes, I agree, but only in this context. And so I guess Peter then sort of collated all of our responses, our yeses and nos, and brought it back to the group, and we had sort of an ongoing discussion about, what about this statement isn't reasonable? So for example, one of the main things that we had to nut through were, what is an aerosolizing type procedure? What is a physiotherapy technique where we are risking transmitting the COVID-19 particles into the air, which would then pose a risk to the treating physiotherapist? Now, there was quite a bit of debate about which techniques would be a problem and which aren't. So for example, shall I give an example from my world?
Yeah.
So obviously most of my research has been in inspiratory muscle training in our ICU ventilator dependent patients, which is awesome, by the way, and there's great evidence, but that's a whole other talk. But I did think really carefully about, okay, if we are doing inspiratory muscle training, we are interrupting the ventilator circuit briefly, attaching a device, getting the patient to breathe, and then returning to the ventilator. It's not the training itself that's the problem. The problem is that break in the circuit that then potentially is making the COVID-19 particles in the air, and then that's the issue. Mm-hmm. And of course, if we have one machine that is being used between patients, that is also another issue. But I had to think about the physiology and the logic behind it and go, even though these patients are likely to be on a ventilator for many weeks or months, even though they are almost certainly going to become very weak in their respiratory muscles, it's not a reasonable thing to do this particular technique given the risk to the treating staff. Mm-hmm. What we'll need to do is accept that to manage the risk to staff, that we don't offer this treatment, but instead we are aware of the residual respiratory muscle weakness they have, and we tackle that down the track with some therapies, with some training that we know we can do, but once they are no longer infectious. And I think that being able to think through that, drawing on my sort of expertise in a very short amount of time, was an extraordinary thing to be able to do, and to, okay, hey, this is my best judgment based on what I know. So if you can imagine, all sort of 15 of us were using our expertise for each of those statements and trying to bring it forward and recommend the relevant literature, the relevant papers, so that when Peter pulled this whole document together, it was informed by the best evidence we had at the time, and some logical, physiological type sensible reasoning as well, but that it wasn't just one person's decision. Everybody got to be part of that. And look, honestly, for some things it's difficult. For example, if you think about bubble PEP as another example, we had some debates and discussion about, well, is bubble PEP an aerosolizing procedure? And I'm not sure that we actually have the data precisely on the different types of PEP and how much is aerosolizing and how much isn't. And again, when there was doubt, I guess the group ended up going in a conservative direction, because again, we need to be able to look after these patients, but we're also looking after the physiotherapists treating these patients, because if we don't look after our frontline workforce, then we can't manage this epidemic. And so I guess that's a couple of examples of the thinking process that went through it. But just imagine that times 15 right around the world in a really short space of time. So within literally 24 hours, a lot of this thinking was happening and was being shared, and Peter was absolutely brilliant in pulling all of that together.
And I think that's a valid point, because we, in terms of managing this pandemic and in terms of managing the virus and the disease that comes with it, is we just don't have consensus on how best to do that. I mean, we have experiential learning, and we are fortunate in some respects as countries to follow from China and Italy and other countries, to say, who have been so open about sharing on their networks and through social media about some of the strategies they've used. So we kind of have a bit of a forward foot in terms of managing this and in terms of our preparation. So we kind of knew this was in the UK, and to similar degrees Australia, we had a couple of weeks to turn this round and get our workforce prepared. And a big part of the beginning of the document is about preparing your workforce and how can you work differently. And you've got to get rid of the Monday to Friday chest physiotherapist. You've got to start thinking more operationally, strategically. And I think that's where the leadership came in the team, to think, okay, we are defining ourselves as respiratory leaders, respiratory experts. So what do we want to tell people? Because people will look up to people in that group and think, okay, they're saying this, so this must be right, or they're saying that and this is what they recommend. They really believe that. So I think that's a really important point you just made. The information gathering was from a number of sources. It was from the evidence we know, it was translating the evidence, it was then information seeking from other countries, and all the contacts that we had. And Alice was incredible for that, as was Rick, as was Michelle, and looking at our partners across Europe to find out what worked well for them and what didn't. So in terms of how we put that together and how we reviewed that together, was selecting which evidence, like you said, was graded, was relevant, that we could actually, as a group, get consensus and say, that is actually, we've got no evidence for that, but that is actually the right thing to put in. So as a group, and I think doing it as a wider group, it's relevant because you want to get as many opinions as you can, but not too many, so you become so diverse that nobody agrees on anything. And I think that's where we were fortunate, wasn't it, that we did agree, and we didn't get full consensus on a few points, but we did for the majority. So now we'll have this document, and we don't need to go through the full document because you can access it online for free, and it is in press. And we'll have to do a shout out for the Journal of Physiotherapy, because there was such demand for this document that it's in press and it has been pre-released so people can use it. So we're really grateful to the editorial team for that. But how is this going to be implemented? So physios now across the world, this has been shared on social media, and it's had a reach of over 60,000 people already, okay, in less than 24 hours. So we've got this bit of paper. What are they going to do with it?
Yeah, look, I think I know locally and around the world that physiotherapy managers are saying thank you, because there was a tweet just this morning from someone saying, look, I felt really lost and not knowing how to make my team safe. Now I feel like I can take this document and know what we need, and actually advocate for my team and have a really clear sense of what's reasonable and what's not. So physio managers can now have those conversations with hospital administrators, with their intensive care team, going, hey, this is what we need to provide. This is the resources that we need. And they can do that with a lot of confidence behind them, that it's not just their opinion, that this is absolutely supported by an international group of experts in this space. And I think that's extraordinarily empowering. And the feedback that the whole group has had from frontline clinicians and managers saying, basically, thank you for giving us this as a tool to really make some decisions now about the staffing that we need, and how we can improve the resource planning side of things, because the decisions that are made now are going to have massive impacts in the weeks and months to come. So I think empowering our frontline managers and administrators early has hopefully literally saved lives, because we are making sure that the physiotherapists are protected as much as they can be, and are only treating those patients for whom physiotherapy is indicated. What we really didn't want to happen was for physiotherapists to just be thrown in and treating absolutely everybody, particularly where there's no benefit of physiotherapy. And that's something I hope comes through loud and clear in the document. And even this morning, since the pre-release of this document, the group members are saying, we're hearing stories of a lot of physiotherapists out there around the world who have just been thrown in and are treating these patients without any personal protective equipment. And that is really deeply worrying, because this is very clear in our document that, in fact, this is an essential part of delivering physiotherapy, because arguably we're fairly high risk. Every time we make a patient cough, every time we're working on sputum clearance, even mobilization itself can be, potentially quite dangerous. And so we really need to make it clear that, yes, we can make a difference. Yes, we can help these patients, but we must ensure that our physiotherapists are protected in this high-risk role. So I hope that is the very practical way that this document is going to influence our practice around the world, and really make it very clear who are the patients that we should be focusing on, and who should we just be having phone call conversations with and not even step inside the room. That's actually really important and valuable and empowering. We don't want physiotherapists to think we need to see every patient with coronavirus. That's just not the reality. And so hopefully this empowers both clinicians and managers to make some smart decisions and to make the most of our limited workforce.
And I think that's a really valid point, because we wanted to set the task of what is relevant here. We'd heard, and part of it was because there was stories coming out from particularly some parts of Europe that physio is not indicated, you don't need chest physios in ICU, you don't need physios seeing these people. And actually we wanted to redefine our role and say, are you crazy? These people have severe viral illness, like they're going to be intubated for, even if it's a short period of time, it's high intensity ventilation, and proning, there's impacts of proning and just fatigue and ongoing breathlessness and oxygen requirements. So I suppose we wanted to make them all mark, but what we were really clear about is actually this is the time to say them, not now. And just because we can, we shouldn't. And particularly within the high viral load stage, because we had no evidence that we needed to do anything. And it's thrown everything out the water that we need to assess these patients every day. We need to listen to chest. We just haven't got the tools that we maybe had before, but how can we still be effective? So that again is a really good point. And I know we've got some feedback already about the guidelines, and I think is there a plan for version 2? Are we looking?
The group has already had that discussion, because clearly, this document was written with the best that we knew at the time a week ago. And as we all know, things are changing dramatically day by day, week by week. And so indeed, in a month's time, we will have more information. We will have more experience to draw on. We will be able to update this guide. And in fact, we will need to as that evidence emerges. And so I guess this version 1 is absolutely an important step in the right direction. But of course, it's going to need to be updated in the coming months. And we will keep listening and learning from our colleagues who are unfortunately in the thick of it. I mean, in Australia, we're a little bit fortunate insofar as our wave is behind what's happening the rest of the world. But, we're hearing stories out of Italy in particular about, say, when you mobilize a patient very early on in this process in ICU, that they desaturate really rapidly. And so, being able to share that sort of anecdotal information with our sort of global physio audience, I think is hugely valuable. We're not saying necessarily that you don't mobilize them, but just being aware that maybe we just have to take it a little more slowly. We need to monitor oxygen a little more carefully. I think that sort of information is incredibly powerful. So the more that we can listen and learn from those who are working and treating patients with COVID-19, I think then it can only make our document and our guidance richer. So, we're an evidence-based profession, right? It would be ridiculous to say that's, the document we published a week ago, that's it forevermore. Of course, it needs to adapt and evolve.
And then hopefully we'll be able to add in a post-ICU rehab phase or recovery phase, because in the minute we just don't know what the needs are, and that's what we keep saying. Can you try and predict what the needs of these patients are going to be? Rehabilitation. Well, in the UK we're already seeing a different type of patient presentation, younger patients, higher BMIs, with secretion problems from day 5 or 6 on the ventilator. So I think they're great questions to ask, but we just haven't got the data yet. So like you said, in a few weeks time, please do feedback to it on the actual publication is Peter's email. You can get in touch with us via social media, and we have started the international collaboration. So if you're part of that, please do feedback via that channel. And we really do encourage you to network within each of your countries. So if you're sitting there in your country thinking, I don't really know who's out there within my country, reach out. Social media is a great platform, and don't create your own collaboratives. So we use the Slack channel in the UK that Zoe set up, but there's different mediums out there. Some people prefer the WhatsApp groups or just old-fashioned emails. So I think that's the biggest thing from this, isn't it, Bernie, that if you collaborate and you use your resources and your international friends, you can really, it's easier to get the information.
I think there's never been a more important time that we as physios share our stories and share our experiences. And so whatever vehicle you have, please connect with the wider team so that we can all learn from each other, because that's what will help us to deliver the best patient care as we go through this. Because as you say, Rachel, this is not just about now. This is going to be in the months and perhaps even years to come as we work with a number of ICU survivors from this process. And one of the conversations I've had a lot with my local team here in Canberra is, yes, the ICU workforce is important, but there's going to be a lot of work to do in the acute wards and the rehab phases in the months to come. So this is the beginning, but oh my goodness, what a time to be a physiotherapist in the world right now. We are needed, and we need to keep learning from each other every day.
Absolutely. So I'm going to finish by giving a massive shout out to all of our friends who are on this paper, and I'm going to read them out so I don't get them wrong. So Peter Thomas, Claire Baldwin, Bernie, Ianthe Bowden, Rick Gosling, Catherine Granger, Carol Hodgson, Alice Jones, Michelle Cole, myself, George Nobadobelobidus, Selena Parry, Shane Patman, and Lisa Vanderlee. Sorry, George, I still can't pronounce your name right. It's the Georgianers. So thanks very much, Bernie. You've been amazing. And I'm sure we'll be having another podcast soon when version 2's out.
Fantastic. Thanks, Rachel.
Thank you.